clinic to everybody to know what we are dealing with and how to deal with it and what to expect. And so no secrets here or no ambiguity in my presentations, usually just to make it plain and simple. And if it's not, later on we have a Q&A and ask me anything and everything about myelofibrosis, I'll try to help. So, and I built on what was said before about the molecular findings and the approach to patients' diagnosis and prognosis. So next slide, please. I'm going to start with this particular slide because it does divide the myelofibrosis patients in two groups. To the left, we have early prefibrotic myelofibrosis, which was very well described by Dr. Michaels, which is mimicking ET. Patients have typically high platelets, some have a high white cell count. And management, if you look to the left, is typically as we do manage patients with ET because the life expectancy is about 15 years. And I have one more slide on that topic just to make it sure that you understand what the prefibrotic myelofibrosis patients' management and outcome is. And then we're going to cross over to overt fibrotic myelofibrosis or post-ET or post-PV, those that transform from ET or PV with fibrosis into myelofibrosis. So these people, these patients unfortunately suffer, as you see in circled, with from three different aspects of the disease: progressive constitutional symptoms, night sweating, low-grade fevers, itching, bone aches and pains, cachexia, poor performance status, inability to walk, and then progressive organomegaly. 80% of patients have very big spleen, 40% have very big liver, affects the patients a lot. And progressive cytopenias, meaning the bone marrow doesn't work well, anemia develops particularly as a major problem. And therefore, aims of therapy, you can see right there are to improve the quality of life, decrease the spleen, and improve the anemia is the three major areas of concern. A quarter of the patients will progress, unfortunately, to leukemia, but 75% of patients will not. And progressive myelofibrosis signs and symptoms lead to untimely death with the average survival of 5 to 7 years. Next slide, please. Let's talk about this prefibrotic myelofibrosis one more time. One slide. If you look to the left, that's the survival of the patients that were identified as having early/prefibrotic myelofibrosis as compared to patients with ET. So what happened is 1,100 patients in Europe were identified as having ET by experts in the field, and then without the names here, an expert hematopathologist from Germany went around Europe and analyzed all of those 1,100 ET patients and say, guys, no. 20% of these patients have a different bone marrow by virtue of different size, shape, and colors of megakaryocytes. These are the cells that make platelets, if you remember. These people are different. They plugged in the information on the survival of these patients, and this is what happened. To the left, you have now this called early prefibrotic myelofibrosis. Average survival is 15 years, whereas it's about 20 years for ET. Imagine these patients are in 65 years of age on average, so it's close to normal, but it's not absolutely normal. So typical patient, by the way, is 65 with myelofibrosis, right? And so a rule of 15 years average survival. Going to the right, what's the risk of progression to myelofibrosis with fibers? At 15 years, 15%, right upper corner. How about the acute myeloid leukemia? That's the right lower corner. After 15 years, 10%. That's why my rule of 15. 15 years average survival, 15 years, 15% will get to fibrotic myelofibrosis, and after 15 years, 10% will get to acute myeloid leukemia. So it's not that aggressive as it fibrotic myelofibrosis, and we treat patients as ET. We look at thrombotic risk and risk of dying from blood clot, which is the primary goal in ET, and it is a very important goal in myelofibrosis, prefibrotic myelofibrosis as well. Next slide. So this is what we do. These are the guidelines, United States guidelines. We call them NCCN guidelines. You heard ELN, these European guidelines. They're about the same or similar. When we look at the patients, we say, what's your risk of dying? And I'm talking about fibrotic myelofibrosis right now. We do that for prefibrotic, but they have good outcomes. So really talking about people who have projected average survival, let's say 5 to 7 years. We would look at the risk of dying in purple boxes to the left, and say you have either lower risk of dying or high risk. Lower risk, and I'll come to the prognostication in a second, means in general a life expectancy more than 5 years. And high risk means less than 5 years by different prognostic scoring systems. And why is that? Because if you move from the lower risk and high risk box to the right, you see that transplant comes in. And if your life expectancy is projected to be less than 5 years, you say you should explore the transplant as an option. The risk of benefit of transplant is then justifiable because your risk of dying from the transplant procedure is also at some percentage. And if your life expectancy is, let's say, 10 years, you don't want to do the transplant right away because you may be dead from the transplant itself, 10 to 20% or more. So that's why prognostication in the first hand, right? That's why prognosticate. How do we prognosticate is listed in a funny abbreviations at the bottom of the slide, and I'll try to explain this in a slide or two, which will come in a second. But if you move from the left to the right, then you look at not the risk of dying, but you say, are you symptomatic? How do we assess the symptoms is it's important part. A lot was already said about it when we have questionnaires these days. I'll show you them. And then we say, okay, what do we do then? If you're symptomatic, we utilize JAK inhibitors. They will decrease the proliferation of the cells, as it was explained. They will also decrease the inflammation in the body of the patients, and people will feel better, right? So we have three of them in a bold red colors: Ruxolitinib, Fedratinib, and Pacritinib. They are a little bit different among themselves, and I'll explain them and contrast them to a degree possible. And one major factor is that Pacritinib is approved for patients with platelets below 50, and the other one for patients with platelets above 50, because Ruxolitinib, Fedratinib can lower blood cell count as a side effect. Pacritinib doesn't. So this is the simplified way how we do it. And for anemia, there are no listed therapies. I'll talk about it because no therapy has ever been approved as a therapy for anemia. Now, in blue color to the right, JAK inhibitors are not selective for mutated JAK2. All right? We talk a lot about the JAK2 V617F and calreticulin and MPL. They all activate the growth of the cells and activate the JAK2 and that intracellular the pathway of proteins inside the cells that activate each other and make cells grow and cause inflammation. So the JAK inhibitors are not specific for the mutation, any mutation. You don't even need to test the patient for the mutation if you have evidence of patients having a myelofibrosis to help the patients counteracting the growth, so you can envision that the spleen will become smaller, and the inflammation, that means quality of life improvement. Next slide, please. So how do we prognosticate? A lot has been said about it. And I'll make a point that no prognostic scoring system is the best one. And certainly what was said before, when was that developed in the past, make a difference, right? If we are looking at the outcome of the patients that were treated last century, how can this possibly be applicable today? It should not. But that's the only way we can prognosticate. You take outcome patients that were treated 20 years ago, and you analyze them. This was the first prognostic scoring system that attempted to do that, and you see the factors in the left upper corner. These are easy ones to get. And then you see the separation in 4 groups in a box in the left lower corner: low risk, no factor of the 5, 11-year survival, and then you go all the way to high. You have 3 out of 5. Let's say you are 72, you have hemoglobin less than 10, and you have blast in the blood. Your projected survival is only 2 years. Remember the 4 groups: low, intermediate, these are the lower risk because it's more than 5 years, right? Intermediate 2 and high risk are 4 and 2 years. That's a higher risk. These people should go into the transplant if possible. Next slide. All right, since then we learned a lot about the genetics, and we know in the upper part of the slides that people have usually mutually exclusive calreticulin, JAK2, or MPL mutation, and there is a small fraction of people that have none. These, in the upper part of the slide, make an impact on their own. But since then, we learn about people having many other mutations. In myelofibrosis, majority have. And they may have abnormalities in chromosomes that carry genes. You heard about the chromosomes. The chromosome may be broken as well. A lot of abnormalities there, and they may all impact the outcome. So in the lower part of the slide, you have an example of some of these other mutations that have nothing to do with the JAK signaling that appear. When they are present, they may affect the outcome. So there are many, many other prognostic scoring systems. My count is about 10 or 11 at the last count. That was last year. And the message is they are trying to improve, but do they really improve and give us a precision? No. And the next slide is important here. All right, here we have 100 patients were analyzed to the left in the blue box, in blue bar, by this prognostic scoring system I show you. It's called International Prognostic Scoring System, IPSS. And you see different shades of blue. So patients were about equally distributed in 4 different groups, right? Well, a month later, you see those patients and you utilize different prognostic scoring system, which is in the middle. It's a gray color and it's called DIPSS. It has a little different way of calculation. You see the shades are different now, not proportional anymore. I circle 61. So 61% of patients that were IPSS intermediate 2 were now intermediate 1 by DIPSS just because you are using different prognostic scoring system. And you can follow the trajectory here. And the bold black line is to divide the patients higher risk or lower risk. Okay, so when I'm asked in my clinic after diagnosis, is the diagnosis correct? Yes. How long I'm going to live? I'm not going to tell you how long you're going to live, because there is no precision here to tell you, and all of this is based on the past, and we make a difference today. And you will see by the end of the talk how we prolong life of the patients, even without elimination of the disease, with the better therapies. Next slide. Symptoms are the next step, right? You say how long you're going to live, and then how are you feeling? And that is usually too brief in many clinical settings. You feeling okay? Okay, fine. See you next week, right? Okay, this is the objective way or semi-objective way of analysis of the quality of life that Dr. Ruben Mesa and his colleagues here developed, which massively can improve the management of patients. The key word is can. Who applies this in everyday practice? Not too many of us. Not too many of us. In academic centers with MPN specialists, you will usually get that, but not in community setting. It is usually by the discussion by the doctor if the patient is willing to project the symptoms and the doctor is willing to get those and understand them. This is the 10 questions that can be scored from 0 to 10, so 100 points, and you get the score and you can follow it. In general, if any of these symptoms is on a scale 1 to 10 at 5, that's bad. Why would you allow patients to continue at 5? That's 50% terrible. Or the score of 10 or 20 or more out of 100, that's bad too. So remind your doctor or ask your doctor, if you don't have the doctor who utilizes this, to utilize it. You can follow the patients one way or the other, on therapy or off therapy. Next slide. And that's important because, look, these are studies done that say how are patients managed in everyday practice. So here they have patients that are symptomatic, and 23% of patients were still managed with watch or wait, although they have symptoms. There is a lack of the communication or a proper assessment of the symptoms and proper recognition of the problem by the doctor, and unwillingness perhaps to treat early, because waiting for patients to be quote-unquote sick enough to treat the patient. So in the blocks here, you read, despite a significant symptom in untreated patients, doctors still choose in some patients not to treat at all. Not sick enough, right? That's not satisfactory. Next. Right, so what do we expect with the JAK inhibitors then? They're not to eliminate disease. They're not as yet to improve their anemia in general. They are here to decrease the spleen size. You can appreciate the photos that gives you the sense of what's happening and improve the quality of life. These are waterfalls, we call them. Every vertical line is one patient, and anything going from 0 down means improvement. From 0 up in a graph means worsening. And that's the classic study that compared Ruxolitinib, a preferred frontline drug for patients that have either symptoms or the symptomatic splenomegaly, to be utilized, because you can see the waterfall. Almost everybody have a response, but to different degree. The blue is control arm. Most of these were hydroxyurea treated patients. That's why we say hydroxyurea is not a good one for the spleno symptoms. It is JAK inhibitor. Now, the dose needs to be adjusted based on the platelet number. I already alluded to that. And it can cause anemia, and anemia compromises the delivery of ruxolitinib quite a bit. Because it's non-specific for the mutation, it will inhibit the normal signaling in normal person how the blood is made. If I take any of these JAK inhibitor and ramp up the dose, I will become anemic and thrombocytopenic, right? So you have to balance how much you can give. Long term, however, we know that patients can live longer with the control signs and symptoms of disease, and I'll show you that in a second. Next slide. The dose matters for the degree of a spleen reduction. Perhaps for quality of life improvement, 10 milligrams twice a day, and dosing goes from 5 to 25. 10 twice a day is good enough for quality of life improvement, which is the number one goal. But for the spleen, if we think beyond just the quality of life improvement, you need more. And so the higher the dose, the more of the spleen is gone. And you may ask me, why does this matter? I'll show you in a second. Because most of the doctors in the community setting do not really measure the spleen. As long as it's smaller and not symptomatic anymore, that's good enough. I'll make a point that that's not good enough because, look, first, the dose matters. And I would say if you start with low dose of ruxolitinib, escalate to maximum safe dose to get the spleen as small as possible because, next slide, the smaller the spleen becomes, the longer the people live. It's a marker of a success. This is from my own clinic, 100 patients on ruxolitinib way back more than 10 years ago, and we measure by palpation, right? You use your fingers and the tape and measure the spleen below ribs on the left side, and you say half of the spleen is gone, that's in a green color, or less than a quarter of the spleen is gone, and you see the survival. These are survival curves, right? The time is of essence. The green, people live much longer. They all had a similar characteristic at the beginning. So my goal is to get people feel well and decrease the spleen as much as I can as a marker of longevity. That's actually approved indication for ruxolitinib use by FDA. FDA actually recognized this as a benefit of ruxolitinib. Next slide. So earlier intervention matters. You can imagine if the patient has less of anemia or less thrombocytopenia when you start, or a little bit smaller spleen at the beginning, it's going to work much better because you can actually provide a better dose. So this is a table. If you go from the left to the right, you have upper part of the table. These are the studies that led to ruxolitinib approval in more advanced patients. And in lower, in gray color, are patients from other studies since then that treated patients earlier, less sick, intermediate 1 risk patients. And if you look from the left to the right, you have a spleen response that's about half gone by palpation, let's say. You see that in gray color, it's always better. Spleen is better. Less of anemia, less of thrombocytopenia, less of infections that may happen when you lower the count, and less of discontinuation rate. So the message here is objectivize the problem with the symptom assessment tool, the questionnaire. Treat early, don't let people be symptomatic, and start early with a higher dose because it works better and it will provide a survival benefit. Next slide. Fedratinib was approved in 2019 as alternative to ruxolitinib, and if you look to the left in a red box, these are the results. By specific measurement, 37% it says there, that's about half of the spleen gone by palpation. We measure it by volume, by MRI, not to confuse anybody. I utilize the simplicity here. Half of the spleen gone. And then 40% it says symptoms are gone by half, and hardly anybody discontinues during the first few months. That appears to be similar to ruxolitinib, by the way, similar, if you compare the studies. However, where the drug is mostly used, it's after ruxolitinib. This is to the right. So ruxolitinib doesn't work anymore. Doctor says resistant, intolerant patient, what do? You can use fedratinib, and you see here responses about 30%, 27%. That means half of the spleen gone or half of the symptoms gone in about a third of the patients, which is not bad as alternative choice in a second line, after ruxolitinib. Next line. Now, this is a little bit more complicated. That's why it's typically not used in the front line. It's a little bit more toxic, right? If you look at the two boxes, red boxes, diarrhea, vomiting, and nausea come to the top. 66% of the patients have some diarrhea or nausea, so you need to take some anti-nausea and anti-diarrheal. That's the qualitative difference between the two drugs on the safety part, not on the efficacy part. And in the lower red box, anemia, thrombocytopenia, not to go to the details, this is all available to everybody for your expert analysis later on. But to say it's a similar degree of anemia and thrombocytopenia with fedratinib as it's with ruxolitinib. Plus, in the box to the right, this is called black box warning for extremely rare complication of central nervous system toxicity, where fedratinib interferes with uptake of one of the vitamins, thiamine. And thiamine deficiency will cause central nervous system toxicity, so you need to measure thiamine and give it. That's called Wernicke encephalopathy. So a little more extra work in giving antidiarrheal, anti-nausea, and thiamine to the patients on fedratinib. So that's why it's usually used in a second-line setting. Next slide. And then pacritinib was approved a year ago, about a year ago, because it's unique than any other drug. So it's not suppressing any blood cell count. And I'll show you actually it may improve the anemia. What was it approved for? For control of the spleen, and of course it does improve the symptoms. The study that led to its approval, part of that study, partial analysis or subgroup analysis of the study is shown here. To the left, you have a patients analyzed. This is a study for patients with platelets below 100. And the first set of bars to the left is a spleen response, comparing to best available therapy. That's 22 versus 3, so very good. The next set of bar is the improvement in the symptoms. Again, half of the symptoms gone, 32%. So that's the overall population on everybody in this study with platelets below 100. That was specifically for this group of people. And to the right is what the drug was actually approved for based on a subgroup of an analysis of patients with platelets below 50. Because in this group of people, you do not use ruxolitinib or fedratinib, right? So the specific indication, it says platelets below 50, although you can use it in patients with high platelets later on in the course of therapy. But at the beginning, as a first choice, this would be my choice. Look to the right. This is spleen and symptom response. Next slide. It transpired through analysis of the safety that the patients actually may have improvement in anemia. If you look to the left, it says clinical improvement in hemoglobin levels. Right? The hemoglobin is red blood cell count. It goes up in some patients. In the middle, pacritinib reduced transfusion burden in some patients, less of transfusions, and to the right, transfusion burden in patients who received one or more transfusions specifically, you can see it's improving in a quarter of the patients' anemia, which is valuable, of course, in patients, particularly in patients that have cytopenias in general, as extra benefit. Next. Side effects are diarrhea in about half of the patients, and nausea also happens. It does not really lower the blood cell count. Sometimes the tables are misguided. These people were already there with the low blood cell count, so the tables do not serve a purpose here very well. But the patients do need to take antidiarrheal. And it comes, when you prescribe it, it comes with another bottle with antidiarrheal medication, so you can take it. That's the only concern here. Next. And then the question is, who will do well? You remember the waterfall. Some patients do better than the others, right? The spleen goes a little more, and what are the factors? You learn a lot about the genetic complexity. Patients that have other mutations will not respond as well. If you start late, look at the green circles here. If you start late, the patient is transfusion dependent, already very anemic, and these drugs worsen the anemia. How are you going to manage? Or the risk of dying, it says high score. Risk of dying is already high. You're not going to help the patients that much. So there is a lot of evidence that there are multiple factors first that affect the overall outcome, but also gives you incentive to start early rather than late. We always want to tell the patients I tell the patients that there is always expiration date on the medications. No medication works forever. On average, in clinical studies, ruxolitinib works about 3 years on average. And that patients should always look for the transplant as alternative option, whenever that can be done, to do it, because that's the cure. Next. What do we do for anemia? This slide did not change much over 20 years. You check this erythropoietin level, which we heard about before. That's a hormone that we make in a kidney that would stimulate the bone marrow to make some red blood cells. You can measure it, and then you see whether it's adequate or inadequate. If it's inadequate, then you give it. ESA means erythropoietin stimulating agent. You give it as injection under the skin. If it doesn't work, you go to the danazol, which is anabolic steroid, or prednisone, perhaps, glucocorticoid. But not much change here. But this is changing. Next. This is changing because we expect this particular drug to be approved by June. Momelotinib is another JAK inhibitor, and if you look at the cartoon to the left, you see momelotinib on the left side inhibiting the JAK signaling. That's the JAK inhibitor like any other. But it's not suppressing the blood cell count much at all, quite contrary, possibly because what you see to the right, through inhibition of another factor, which is on the surface of the liver and has to do something with the iron metabolism, it's postulated this inhibition of the protein which is called ACVR1, it can improve the anemia. So unlike any other drug, possibly the pacritinib, as I said before, this drug is being developed as the anemia drug. Pacritinib was developed for the spleen, it improves the symptoms, it may improve some anemia, but this drug specifically is tested for anemia. Next. And this is the study, perhaps complicated, just to simplify it in upper part. This is in a second-line setting after ruxolitinib, momelotinib, MMB, compared to danazol, that is the anabolic steroid I talked about. Blinded randomized study which finished last summer, and we have results in a text, in a table in the bottom. I'll just highlight the red colors. That symptom response, that means half of the symptoms gone, were seen in about 24% of the patients. The transfusion independence, no transfusions anymore, in about 30% of the patients, and the spleen, I'm looking at the table at the bottom from the left to the right. The spleen is the last side to the right. Also, half of the spleen gone, about 23% of the patients. That's in the people who failed ruxolitinib second line. We expect this drug to be approved. Next slide. It's going to be particularly useful in people who are anemic. That's the main point here. If you look at the bars to the left, the blue bars, these are bars in patients who were on momelotinib. 13% were transfusion independent at the beginning. That after 6 months of therapy became 31. So it's improving the anemia, right? The danazol is in gray color, didn't do that much. And you see the graph to the right. These are hemoglobin measures over time. They go up. Right, that's the evidence of anemia benefit. So I would expect the label for its use to be for myelofibrosis patients with anemia and possibly with symptoms. Next slide. And the most important part, again, is this survival. There is a suggestion from the recent presentation 2 months ago that patients that become transfusion independent, or in general, people who are exposed and have a benefit of transfusion independent do well, that they have a better survival. Perhaps that's another marker, like we have a marker for ruxolitinib. The spleen needs to become small, as small as possible. That will provide a survival benefit. Perhaps we have here an indication of another marker, transfusion independence, anemia response, as a marker of a survival, because we are not able to eliminate disease these times with any of the medications. But we can control it much better than in the past, and we make people live longer with better quality of life. Speaking of that, next slide. I was here first time in 2005. And so I'm now 18 years old. And I'm ready to discover the world, right? And just to reflect on my participation here at every meeting ever since. I have another slide, please. This is what was the state of affairs at that time, 2005. I was asked to talk about what I'm talking about today, management of myelofibrosis patients. This was the understanding of the biology at that time. You don't see any JAK, calreticulin, or anything there at all. This is from Dr. Teferi's review, which was the top-line review at that time, I think even in a major journal, JCO, some of you may recall. And I borrow this for presentation and say, this is what we know and what we don't know. And any of these abnormalities here, and there are multiple these abbreviations and whatnot, are a possible target for therapy because we don't know anything specific. Next slide. And this was my plan at that time, 2005. We're going to do all of this, and we did actually. But a few months later, this was February 2005, a few months later there were all these publications saying JAK mutation is out there, and it's in almost everybody, which is not true, unfortunately. And it's cause for the disease, not so, we learned that. There are other problems. And we don't have a JAK2 mutation-specific drug, although efforts are in place to do that. But we made such a big progress since then, right? This was the 18 years ago. The next slide. And with the discovery of the JAK inhibitors, this is what happened. Who was here in 2005? I'm sorry. All right. So you may recall my talk at the time. I will use the name, I have a permission. This is Bob. He is one of my patients. He used to come. He came to my clinic in 2008, and he used to show his progress with the photos every so often when I was here every few years. Next slide. This is Bob. He was not able to come last month to see me. He had some other medical problems. He's still alive and well and kicking in Washington, D.C. with a controlled disease. He's not in complete remission or any remission at all. He has a disease. He's on JAK inhibitor, and he's doing well. And we aged together, as you can see. That was the last trip to Houston, but he still goes around. So from 2008, right, to 2023, we are making progress. That's why I don't use any prognostic scoring systems. And I also would like to say, now that I'm 18 years of age, and I had such a wonderful experience, and I am grateful for what we have done together here. It's no one-man action, it's a team effort, it's always it is. That stands for my team at MD Anderson. A lot of different people have been contributing to what happened. And you as a patient are dear to my heart, and I'm grateful for every moment. But it's also time for me to move on. I'm going to retire from MD Anderson by the end of this month and move on to develop some drugs in industry for you and hope to be successful. So we'll be still in touch. Thank you very much.